Good morning, good afternoon, good evening, wherever you are in the world. Thanks for joining us on a Wednesday virtual morning report with clinical problem solvers. Excited to be here. Zavin will be joining shortly. And hope everybody's had a great week. Congrats to everyone who had match day on Friday. No matter where you ended up and where it was on your list, just exciting to move ahead with the next step in your career and know where you'll be and you'll flourish. I saw just some great stuff on social media around sort of the mixed emotions of the day and how ultimately it's such a unique thing in medicine and training in the United States um, that is pretty defining to all of our experiences. Um, Zavin will join shortly, as I mentioned. I'm going to start by reflecting on yesterday's neurology virtual morning report, which was really expertly discussed by Aaron and Sukriti, who's with us again today, and then Kirtan. It was a case of a gentleman in his 50s with chronic progressive cognitive changes in the form of some memory issues, difficulty kind of doing executive function in terms of doing his ADLs, and then ultimately really a decrease in kind of his speech output and increased confusion right before the hospital admission. The team really nicely tackled from the very beginning just the broad topic of altered mental status. And what was really nice to hear is their discussion very much classified by time course, starting with time course before sort of tackling etiology. And I really love the breakdown very clearly in what can be hyperacute versus acute versus subacute versus chronic, with the hyperacute change in mental status really having a fairly limited differential diagnosis of vascular events, seizures and their post-ictal state, immediate trauma, or something like intoxication. With the kind of acute stuff being, I think, acute meaning instead of just onset over minutes to hours, hours to days, really broadening in the infectious, inflammatory, and toxic metabolic categories, and then really moving through subacute and chronic with expanding on those, of course, with chronic really being the place where degenerative conditions and then certain infections with longer time courses coming to play. The conversation really shifted when we found out the past medical history of this gentleman included Crohn's disease on infliximab, as well as chronic steroids and azathioprine. And the group really started focusing on considering his immunosuppression in what could be going on for these chronic cognitive changes. And then I thought most helpful sort of as a review was kind of hearing their discussion about some of his ataxic findings that he had both on history and exam. He had dysmetria and dysstatokinesia on the left side during his assessment, as well as a slow and wide based unsteady gait. And the group really made a nice teaching point to think of ataxia not as something that is definitely in the cerebellum, but remembering very clearly the cerebellum requires both afferent and efferent output. So you actually have to gather the sensory data, bring it up the spinocerebellar tracts into the cerebellum, and then bring it outward for actual motor execution, and really making the point that when we see someone who has ataxia, we really have to think about the entry, the cerebellum itself, and then the exit out to be able to interpret where the actual lesion is. In the end, the brain imaging this gentleman ended up getting showed a really large area of demyelination, without associated mass effect at all, with very little surrounding edema, which in the setting of immunosuppression really made them worry about an infectious demyelinating condition, specifically PML, which stands for progressive multifocal leukoencephalopathy, which ended up being the diagnosis. This is a diagnosis of an infectious demyelinating condition that happens in the presence of JC virus. Historically, in the past, was seen most often in patients with HIV/AIDS, transplants. But now with our expanded use of immune modifying medications for a lot of reasons is seen frequently in patients on strong immunosuppression, as this gentleman was. So a really wonderful discussion taking us through mental status classification, really using time course as our first anchor, followed by a discussion of what defines cerebellar, and it's not, what defines ataxia, and it's not just cerebellar, and then really a reinforcement of our illness script of what PML is like. The case had a sad outcome, unfortunately, as happens with that diagnosis, but certainly a lot to be learned with that beautiful discussion. All right.
Hello.
Zavin is here. Just had a dental procedure, but look at this commitment here. Smiling at least halfway as much as you can for the case. So let's see what we've got here. Did I see in there that Fernand, I know I saw you're here, Fernand. Was that just my eyes? Oh, Fernand's got a case. Okay, awesome. Really excited to hear that. And yeah, just looking for a couple discussants now. And we can hang out a little bit and see who's interested.
When the lidocaine wears off, I may regain my hemiface function for a more symmetric smile. But then if it hurts, I may not be smiling anymore.
Good point.
Would anyone with or without dysarthria like to discuss with me? All right, Kirtan.
Kirtan, great. Oh, great. Wonderful. It will be great to have you. Oh, that was the other nice physical exam pearl that Erin kind of reinforced, is that dysarthria, the actual production of words, really can vary if it's affected because of the face not working well, the tongue, or the oropharynx, the palate, with the test of asking people to say different words. So we could try and diagnose you now, although I can see where the lesion is just looking at you, but saying pa, pa, pa with lips, la, la, la with the tongue, or ga, ga, ga with the palate. How's your pa, pa, pa?
I actually didn't have a dental procedure. I just injected some lidocaine into my own alveolar nerve just to demonstrate this. That is the level of commitment to teaching. Pa, pa, pa. Da, da, da. Ga, ga, ga. I think I'm good.
You're good. Yeah, you're good to go.
All right. Anyone want to join Kirtan? A woman would be great, but yeah, please volunteer. We'll have a good time learning together. And as always, I truly believe that even though it's a little bit understandably a higher activation energy, you do get so much more out of it in terms of your own learning if you take a more active role. So very much encourage everyone.
Mario, wonderful. We'd love to have you. Thanks for joining. Maybe we could start and have Kirtan and then Mario and then Fernand unmic yourself, introduce us, let us know what you're up to this week, and then we'll get started. You can go ahead and start, Kirtan.
Yeah, so hello everyone. I was very excited to participate again. So suddenly, I just participated yesterday and I thought that today I might not get chance, but fortunately no one else was volunteering. So I got the chance and I'm looking forward to discuss the case with you and Zevan.
We're really excited that you're here. Thanks for joining. Oh, and then I remember from yesterday, but do you mind letting people know where are you joining us from in the world and what do you
Yeah,
do?
sure. So I'm a final year medical student from BJ Medical College, Ahmedabad, which is situated in the western part of India. So I am from Ahmedabad.
Thanks so much. Mario, over to you.
Yes, hi everyone. My name is Mario. I'm a 6th year medical student, which is equivalent to a 3rd year. I think in the States. I'm from Lima, Peru. And yes, I discussed a couple of times and really excited to be here again. I really enjoyed Kirtan's discussion yesterday. I think it was really masterful performance. And Fernand's cases are always really tricky, so really intimidating. So we'll try to do my best.
Completely agree with you, Mario. It's great to have you back joining us again. And Fernand, you want to say hi, let us know who you are, and then we'll kick off the case.
Yeah, hi everybody. I miss everyone. It's been a while. I haven't been here, and I'm a first-year fellow in hematology oncology at Albert Einstein College in New York. And I'm bringing you a case from my busy weekend, but it was really interesting. Actually, I have plenty of cases, but I'm going to share one particular with you. And it's something I learned a lot from it, and I guess there's a lot for everybody to learn from it. So
Can't
should I
wait for
start?
you to teach us. Yes, go for it.
All right, I'm trying to figure how I'm gonna frame this. It's a 60-ish-year-old male coming because he's having difficulty breathing and some upper abdominal pain acutely. But then at the same time, he mentions that he's been experiencing some abdominal pain over the last 3 months. And he denies fevers, chills, nausea, and vomiting. In the ED, on exam, he was found to have like tenderness in the upper abdomen, and he looked pretty sick. I'll stop there.
Kirtan, do you want to pair up and go first, sharing your thoughts on what we've heard so far?
Yeah, sure. So we don't have a lot to go as of now, but from what I can make out that the patient was relatively all right, and then he started to develop difficulty in breathing, and there was evidence of acute on chronic abdominal pain, and without any clear signs of any sort of inflammation or infection, because there was no evidence of fever, nausea, or MSAs. So first, I would like to figure out whether we are dealing with a pathology that is primarily located in the thoracic cavity or it is located in the abdominal cavity. So that's kind of broad differential that we should have in mind, that whether the pain that the patient is experiencing in the abdomen is actually due to some pathology in the chest, or it is the other way around, that some pathology in the abdomen is causing difficulty in breathing. So we can think about conditions which affect the peritoneal cavity, like ascites. Ascites can present as diffuse abdominal pain, and let's say the patient now develops spontaneous bacterial peritonitis or some sort of infection, then that can present as acute or chronic abdominal pain. And ascites can also pull on the diaphragm. I mean, it can push the diaphragm upwards, so that can present as difficulty in breathing. So that's one way to look about it. Apart from that, any pleural conditions, any chronic pleural conditions can present with abdominal pain and can also present with difficulty in breathing. I mean, the time course would be the key here, whether the difficulty in breathing is acute or it is chronic, it has been progressing suddenly, or it has been taking some time to progress. We can think about interstitial lung diseases, which can present with chronic difficulty in breathing. And as of now, it's difficult to link the abdominal pain with the chest difficulty, breathing difficulties, but let's see what else we can have.
Very well said. Yeah, there's. I like to say that there's not a hermetic sort of trash bag between the chest and the abdomen, and there's a lot of communication both in terms of potential mass effect as well as tracking of inflammation across the diaphragm. So I love the way you described that. Yeah, I think there's sort of, we could randomly pick out individual, kind of conditions and narratives based on the very limited information we've heard so far. Everything, you gave one example of peritonitis with SBP, right? Or I don't know, it could be pancreatitis with ARDS. There's a lot of things that we could just be throwing darts at a million possibilities. And I think in these cases, it's helpful just to actually hear more about who the patient is and more of the details of the kind of chronologic narrative of which symptoms started first, the details surrounding that symptom, and then how things evolved. So I think I have a feeling this can be a very rich case. Maybe we should just kick it back to Fernand to give us more information.
Oh, you're still muted, Fernand. Hey, Fernand, you're still muted.
Okay, I am gonna give you all the context, like the past history, and I want to give you some updates on the evolution, like the initial working diagnosis, the evolution, and then this will set up more thinking, I think. Our patient has a history of essential hypertension. He has PUD and had a perforation in a duodenal ulcer in 2014. Had a resection of a sacral and parasacrospinal globus tumor in 2020. Surgical history, that was his main surgery. The medications he's on, the patient is on amlodipine, he's on cyclobenzaprine, he's on lactulose for constipation, omeprazole for his peptic ulcer disease, and tamsulosin. He also has BPH. You can add this to the past medical history. Family history, mother had high blood pressure. He doesn't know anything about his father. Social history, patient does not drink, does not smoke, does not use drugs. I do not know what he works. And he doesn't have any known allergies. So in the emergency department, in terms of evolution of this case, a patient got a CAT scan, which showed marked distension of the stomach. There was pneumatosis in the stomach and the proximal duodenum. There was a clear perforation of the duodenum, and there was extensive portal venous gas with pneumobilia. So the patient was diagnosed with another perforated ulcer in the duodenum. You can imagine this was a surgical case. The patient went to the OR immediately, and then he got a repair, which was a resection of a portion of the area. And at that point on presentation, he had a lactate of 17 and AKI of the creatinine of 2.32. He got fluids, antibiotics, went for a repair via a laparotomy, and there was a creation of a gastrojejunostomy. So we thought that everything is going to be fine after that. It's just a simple process. Then the patient stabilized. He lost some blood, but his hemoglobin stabilized. But then after that, he started bleeding again a few days later from the NG, drop in hemoglobin, and hemodynamic instability on pressors. And then the GI doctors went through with an EGD and found the spot that's bleeding at the anastomosis. They clipped it with 10 clips and epinephrine. We thought that this was the end, but patient kept bleeding. The NG output was high, the pressors kept going up, and it was becoming really tricky. So hematology was consulted at that point to help. And I'll stop here so you can give me your thoughts and we'll go from there.
Thanks, Fernand. Wow. hearing that you had a busy weekend, and then this was one of the consults on top of your many consults. Just kudos to the great care. I'm sure you gave many patients, including this complex one. Mario, if you want to unmute and just share your thoughts on all the information we've gotten.
Well, I think this is like in terms of management, it seems to be a very challenging case. And I think what comes to mind in terms of the diagnostic workup is what is driving this peptic ulcer disease? Is it just maybe well, the most, at least in the developing world, the most common cause is Helicobacter pylori infection, but also other maybe not so a lot more common stuff. We know he doesn't drink. Maybe NSAID use doesn't appear to be the cause. So that's one thing I would be tracking. And for example, another thing is why this patient continuously bleeding. It seems that they can't control the source. So things that come to mind is this patient does this patient have, besides this perforation, some type of coagulopathy, thrombocytopenia, or something that's impeding the clotting and the cessation of the blood loss. And I know, for example, I think this may be a stretch, but I know Helicobacter pylori can cause thrombocytopenia. So maybe that's something I would be tracking. Besides that, how does this subsacral or parasacral spinal globus tumor tie in with all of this? I don't know. I think it's a type of vascular tumor. I think it usually, I remember seeing in the extremities, like in the hands, but I think it can happen in other places. Maybe this ties in with that. I'm really not sure. And it seems that this hypertension is true and unrelated, and it's just essential if it's controlled with just amlodipine. So yeah, those are my thoughts right now.
Thank you, Mario. I had that exact same question pop into my mind when we heard this poor guy has now had 2 perforated ulcers. Just wondering what is driving this ulcer formation in this gentleman. And I love your thinking through, in the background. That's something we're going to have to sort out once we fix his hemorrhagic shock, which has been evolving post-operatively. But I love the discussion of potential Helicobacter pylori infection, high-risk medications like NSAIDs, and then we can think about endocrinopathies as well, such as the gastrin production of Zollinger-Ellison syndrome. But what's most immediate is this guy continues to bleed post-op. So I really think that your thinking in this condition is really important. I think before we tackle that, so far to me, the story makes sense of how he presented the way he did, right? Sort of Kirtan and Zavin's thoughts about, what could be happening that could make it both difficult to breathe and have abdominal pain. Certainly, we've got a great reason for the abdominal pain, and whether it hurt even to move his stomach a little with breathing, or the severe acidosis that he had with that lactate of 17 was making him dyspneic. I think there's no question why he came in with those symptoms. The challenge now is, what do we do going forward? So we're really talking about, post-operative bleeding that's very severe. I mean, we're not talking about oozing from the wound site. Fernanda's telling us that this gentleman is in hemorrhagic shock, requiring blood products as well as pressors in the ICU, and that it hasn't stopped even after an impressive 10 clips put in the area of anastomosis. So I think we have to sort of go back and just think very broadly right now about what it takes to stop an area from bleeding, right? And make a clot form and make it heal. And it really comes down to the 3 big categories of the stability of the vessel itself, the platelet plug that forms as primary hemostasis. And we can think about, is it going to be a platelet number problem? Like you alluded to, Mario, there's some potential background diagnoses that could drive thrombocytopenia in this gentleman. Is it a platelet function problem where the platelets number is fine, but they're just not doing their job? Or is it something with the coagulation cascade that's causing a true coagulopathy and preventing the ultimate sort of fibrin bonding and formation? Now, this guy had labs preoperatively, right? So we can assume there was nothing so profound and obvious in terms of his platelet number or his PT and PTT pre-op. This was a very emergent surgery, of course. So perhaps there was toleration for some abnormalities more than there would be, because this gentleman would have died without that. But I think getting particularly finding about sort of if we're going to have a true quantitative problem versus a qualitative problem is an important thing to just think broadly about now, since we knew he was, taken to the OR. Again, I want to emphasize this was not an elective procedure, it's extremely emergent. So maybe they did take him to the OR with platelets of, 15,000, and they just were going to work around it to save his life. So I think we just need to think through all those categories going forward of what it takes to stabilize a vessel. Let's just stop there and we'll get some more info from Fernand.
Can I just make one comment? Both Mario's and Steph's discussion just now was awesome. But so much of clinical reasoning is just filtering an appropriate problem representation, right? And Steph, did it so well, but very subtly that I just want to underline it. Basically, she said, dyspnea, abdominal pain, like no surprise at all. And the way that I heard you frame it, I think, was basically recurrent gastroduodenal perforations now with like problems with hemostasis, and that's what you focused your discussion on.
All right. I love the discussion so far, and I agree that this is it needs to be a double-pronged approach. We have to fix the anatomical problem, but when it does not work on its own, there might be something else. So we have to work on everything together when somebody is on 50 micrograms per minute of norepinephrine. So I'll give you the pre-op labs. I'll also give you the exam, and then the post-op labs when we were in a refractory shock, and then you will be able to analyze them. So he was afebrile. The heart rate was in the 70s. Blood pressure was artificially kept above 65 on norepinephrine. This is the map. And there was a substantial amount of norepinephrine with vasopressin. Patient was intubated and he was setting at 99, 100% on the ventilator. General exam, the patient was sedated, although at some point I saw him lightly sedated. He was able to open his eyes, not really interact. Head and neck exam from the outside. I mean, there's nothing obvious, no deformity, no lymph node that I could palpate, no crepitus. Cardiovascular exam, the heart sounds are there, they're not muffled, no significant murmur. I can hear breath sounds on the ventilator, they're symmetric. The abdomen, I mean, it's really hard to examine it. It's not distended. When I felt that was post-op, there was a scar that's healing. Didn't seem like there's an abundant amount of blood like outside of the stomach, or like it didn't feel like wood. There was an NG tube with some bloody output, and there was a rectal tube with some dark output also. Neuro exam I could not examine because the patient was kind of sedated, and there was nothing obvious on the skin. There was like no purpura or bleeding on the skin. Pre-operative labs, the CBC in the emergency department, we had a white blood cell of 5.8, hemoglobin of 6.7, knowing that a year ago he had a hemoglobin of 10.2. The MCV is 82. The normal MCV is 100 at baseline, and the platelets were 574. I'll also give you the baseline coagulation abnormalities because it's important, as Steph mentioned before the surgery. And the PT was 15.7 with a 9R of 1.2. and a PTT was 34.6. So after the surgery, so the surgery occurred overnight. I mean, after the surgery, just the next day, the patient had an INR of 1.7, a PTT of 48.6, and the PT was 20.2. And just like regular, and the hemoglobin dropped to 5.1 from presentation. You can expect that. And let me give you the BMP.
Fernand, can you clarify those pre-op coags? They look a little funky. PT was 50?
15, 1.5.
Oh, okay. And then do you know how much blood and products he got intraoperatively?
So I remember that when I counted them, like during the initial period of time, he got a massive amount of transfusion. I read something around 14 units, 1/4 of PRBCs, with at least 3 units of platelets, 3 units of FFP. Post-operatively, I only gave you the PTT. Let me give you the full CBC. So it was a white blood cell of 2.6. The hemoglobin went up after these transfusions to around 9.4, and the platelets were 273. And let me just get the BMP out of the way.
Spoken like a true hematologist.
No, I still recommend a lot of internal medicine things in my note. Sodium is 147 on presentation, potassium is 4.8, chloride is 107, bicarb was 9, you can imagine with the lactate, the gap was 31, BUN was 34, creatinine was 2.32, magnesium was 3, phosphate was 8.8, alk phos was 133, AST was 32, ALT was 23, albumin was 4, bilirubin was 0.4, and lipase was 167. So post-operatively, the AKI improved. There's nothing major in the BMP that changed. But as I told you, the bleeding persisted. There was still a drop in the hemoglobin, and there were these coagulation abnormalities that appeared after the surgery, and that I would like you to interpret. In terms of imaging, there was just this CAT scan that I mentioned on admission, which showed the perforation with pneumobilia and portovenous gas. And that's all I have for now. How would you approach this?
Thank you, Fernand. Kirtan, how would you approach this?
Yeah, so very interesting developments now. So first focusing on what Mario and Steph discussed earlier, that what can be causing all these recurrent perforations. So thus thinking about few possibilities, like as the Steph mentioned that it could be Zollinger-Ellison syndrome, and we can think about excessive production of histamine, something like that. So systemic mastocytosis, certain myeloproliferative neoplasms like polycythemia vera, stuff like that. Then CML can sometimes present with recurrent perforation, electrolyte abnormalities like hypercalcemia can trigger the acid production. And very interesting thing that the PT was slightly elevated. Now, of course, we can think about delusional coagulopathy component that can be all this process, and it would be helpful to know how the fibrinogen levels were, because if the fibrinogen levels are low, then we can be assured of the fact that there can be a component of delusional coagulopathy. But let's say if it was not the case, then the fact that INR was slightly elevated makes you wonder that what if there was some evidence of vitamin K deficiency? And if that is the case, then probably, as the Steph mentioned, in Zollinger-Ellison syndrome, we can even get the component of malabsorption because there is so much acid that pancreatic enzymes can't function properly. And therefore, we can get deficiency in absorption of fatty soluble vitamins, including vitamin K. And then about the Globus tumor that were present in the paraspinal region. Now, I'm not sure how to connect it. I mean, we have things like multiple endocrine neoplasia, Carney's complex, Carney's triad and stuff, but it's hard to figure out how to combine that with all other findings. And as for the lab, I'm lost. I mean, is this a form of DIC? Is it a form of acquired coagulation factor deficiency? It's really hard to figure out. So can you help me, Zevan?
I don't know if I can, Kirtan. Your fund of knowledge is just incredible. I think you covered the bases. Thanks for expanding the differential on the causes of recurrent perforation. By the way, I think there was some stuff in there that I didn't know actually about CML and hypercalcemia, predisposing to those potentially. But as far as the coagulopathy goes now, pre-op he was really within limits of normal. I mean, honestly, I think we would be nitpicking a little bit. I almost never look at a PT because it's the INR that kind of normalizes for the lab's parameters, right? And the PTT is borderline, but I mean, they're normal, right? But the reason I was asking, and we heard about that massive transfusions, is what you mentioned, which is that anytime you are losing blood, you're losing whole blood, right? But what we tend to replace first is the red blood cells, because that's what we kind of look at and worry about most, is oxygen carrying capacity. And if you lose enough whole blood and replace it with enough red blood cells alone, you're not replacing the platelets, you're not replacing the coagulation factors, you're not replacing the calcium. You can develop this coagulopathy just because you have diluted down basically those clotting elements. So just looking at the proportion, for example, of red cells that were replaced, 14 units of red blood cells is basically an entire person, non-anemic person's blood volume. And the getting only 3 units of FFP, that's not proportional. So I think just de facto, I would say, this person has almost certainly an element of dilutional coagulopathy and factor deficiency because of the massive transfusion that kind of was a little bit heavy on the red cells and not heavy enough on the clotting factors. And I would want to give this person FFP to account for that. Is there DIC? Yeah, almost by definition, the degree of sterile tissue injury with the hypoperfusion, the infectious element that almost certainly exists in a case like this. It would be surprising if there wasn't just an element of a little bit of clotting and consumption, whether via DIC or even just like local hemostasis, right? Also takes consume some of those elements. So I think for both of those things, what you do is supportive transfusion, basically, right? Supportive care. And I think if you look at the pattern of coagulopathy with both the INR elevated and the PTT elevated, that either means that all factors are being consumed sort of symmetrically, or if there is an isolated deficiency, that it's downstream of the convergence, right? So it's not factor 13, 12, 11, 10, 9, or 8, because that would be PTT alone. It's either 10 or it's 2. That's where kind of they come together, and that's what, if you're kind of ignoring the dilution and ignoring the DIC, that's what you would have to invoke for more of an isolated, factor deficiency. And again, I think it's unlikely that that's what should be going on in a case like this, but since we're talking about it just for completion, when you get isolated factor deficiencies, generally it's either congenital, which in a 60-year-old man, you should know by now there should be some history of recurrent bleeding, although maybe, again, this case is acute enough that we just don't have access to that history. It doesn't mean it's not there, right? Or when you have an acquired isolated single factor deficiency, it's generally an autoimmune process, an autoantibody against factor 8 or 9 or 10 or whatever. And that is usually secondary either to a malignancy, it's a perineoplastic syndrome, or can be triggered by certain infections. It's usually sort of more atypical kind of viral infections. It's associated with HIV and CMV, or it's part of a broader autoimmune process and associated with lupus or something like that. But again, I think given this clinical context, I just think all of those things are less likely. The globus tumor has been kind of nagging me in the background all along. Because you just, there's not a lot of globus tumor out there, right? And we don't know a whole lot about it. It is, I think, Kirtan, you said it's a vascular tumor. So, you wonder, I don't know, like, can it be multifocal, and could it also be somehow in the mesenteric arteries, or wherever it is? I think it can cause some mass effect. So, or if it's infiltrating, obviously that's then when you cut cancer, it doesn't exactly heal very well and can continue to bleed and can kind of. But again, I would have to learn more about it. But again, it would just surprise me probably if this was related to that presentation, because they tend to be kind of more local and benign rather than sort of metastatic. So I'll stop there in terms of just kind of reacting to some of the labs. I'll just point out one thing that I thought Fernand did so well in his interpretation of the vitals, or his reporting of the vitals, where he just said the map is artificially kept at greater than 65. Any patient who's on pressors has a blood pressure of 90/60, because that's what the bedside nurse is adjusting the pressors to, right? So if you want to interpret the hemodynamics and how bad the shock is, what really matters is just what dose of pressors they're on, right? And in this case, it sounds like they're both on vasopressin and norepinephrine, meaning, and I'm guessing the norepinephrine is a non-trivial dose, meaning that they're still in significant shock. Fernand.
All right. Really nice discussion. So when I went on board, I was looking at the case initially. I had similar thoughts, like maybe this is delusional coagulopathy. So let's just balance the transfusions, like do more FFP. And they have been doing this actually for a bunch of days. But let me tell you how the coags evolved. So I gave you a PTT of 48 just the next day post-operatively with an INR of 1.7. The INR normalized with the FFPs. The PTT went up to the 50s, 60s, then went down to the 50s, then went up to 91. And throughout all this period, patient has been bleeding, FFP, platelets, etc. Fibrinogen has been around 200, 180, 190. And I get on board at that time. I say, let me look at a smear. So I looked at a smear. There were no schistocytes. And so the team, the ICU team has just been transfusing, supporting the patient, but there was something really weird. So I said, let's get a few additional labs. We got a mixing study.
Did not correct.
So the mixing study, the immediate time was 47.8. The 2-hour post-mixing time was 72.3. The PT mixing study was 15 seconds. And I can give you some factors some factor levels that we got. So just a second. Okay, so factor 9 was 60%. Factor 5 was 47%. Factor 11 was 41%. Factor 8 was less than 1%. And the lupus anticoagulant was negative. So I'll stop there.
Thanks, Fernand. Mario, we got a lot more information here. We learned, I think, just to distill out the most important data, we really identified that it was the PTT, right, that kept being a problem. Before sort of interpreting what happened, do you mind just sharing, like, what do you know about a mixing study? Like, what is that? And if you don't mind tackling kind of how we could start approaching the result for this gentleman for that test.
Yes. Okay, so when I think of a mixing study, I'm trying to figure out if this coagulopathy is from from the deficiency of a factor, or if there's an inhibitor of a factor. And if you mix, if there's correction of the PTT in this case, which is not this case, if there was correction, then we'll be looking at a deficiency of a factor, for example, a hereditary hemophilia or acquired deficiency. I know, for example, I think you can have I think amyloidosis can give you, I don't remember what type of deficiency, but it can give you an acquired deficiency. If it doesn't correct, we should first look at lupus anticoagulant. But for example, in this case, I wouldn't be, I think I would, if we were suspecting a lupus anticoagulant in the presence of antiphospholipid antibodies, but we would expect some thrombotic manifestation, which we don't see. But in the absence of a lupus anticoagulant, we would be suspecting an inhibitor, a specific coagulation factor inhibitor. And I think that's where my knowledge gets me, because I've never seen the percentages, to be honest. I guess the one with the less is the one that's the one that's been inhibited. So I guess factor 8 is the one that's been, there's an inhibitor of factor 8. So I think that's what I would interpret from this workup.
I'm right with you, Mario. Wonderful explanation of the mixing study, right? When we added back someone else's plasma, the problem didn't go away. So there is something in the patient's plasma that's causing a problem with the coagulation cascade, and that is an antibody. And so you're very right. Sort of the next step is, think about, well, what does the antibody do based on the factor levels? And that's where these quantitative, or I should say, relative percent present factor assays come into play. I just want to very, very briefly pause a minute and just say, if anyone out there is feeling, chest discomfort or abdominal pain, hopefully not like this person, but just the whole concept of the coagulation cascade is it's tough to learn. I just want to make a quick plug for, as with many things in medicine, making it simple when you're starting to learn it. And Sukriti, just for 1 second, I'm going to share my screen. There are some nice demonstrations online of ways to simplify the coagulation cascade. I'm going to show you one of them for anyone who's still working and learning. The biggest thing, I think, is get rid of the Roman numerals, right? So whenever there's Roman numerals on something, it's a little bit more difficult. And if you Google coagulation cascade gun, it actually, because you can see it looks like a little kind of handgun shape here. There's just really great ways to start. Now, obviously, there's more to the coagulation cascade than this, but this is actually something that I memorized as a student that I can still draw out quickly, because it's easy to just work with the simple numbers and get a very clear picture of where we are. And as we've talked about in this case, right, with the PTT being prolonged and the PT now being better, we're really dealing with this part. And again, particularly here, factor 8. So I just want to make a plug for kind of how you study this. Simplify it, make it easier for it to stick in your memory, because it's very complicated and complex, and you'll get better with it after a while. Thanks, Sukriti. Back to you. I don't have too much to add, Mario. I think we do see with just that deficit in factor 8 activity, that is where we're getting inhibition and it's not working. The question then comes back to why, right? That's not an end diagnosis. Is it related to, an underlying metastatic or oncologic condition, autoimmune condition? Could there have been a medication related thing? We didn't hear about all the medications he got, and I'm not familiar with anything that causes an acquired factor 8 deficiency with inhibitor. But I think all of those sort of categories, we now need to sort of reframe our problem representation to a 60-year-old gentleman with postoperative hemorrhagic shock due to, functional factor 8, functional factor 8 impairment. We're getting close to the hour. I'm sure there's a lot more to chat about and discuss. So Fernand, why don't we turn it back to you for either more data or case resolution, wherever you want to take us.
So this is case resolution, but a lot of pearls on the way. So I'll share with you the way I started having alarms in my head about something is not right here. This is not simple. So initially I said maybe this is delusional coagulopathy, but then it didn't make sense when we gave him a lot of FFPs, and the big alarm was like the PTT is going up despite the FFPs. And I told my attending physician, something is not right here. The FFPs are not doing their job. This is when I brought up doing PCC. Maybe we need to give much more factors, like in smaller volume, to try to do something. And we started like the conversation that something doesn't make sense. And this didn't feel like the IC, because why would he have the IC? He just had just a simple surgery, and he doesn't have the main causes of the IC, which are septic shock or retains of a dead fetus. And there were no cysticytes. Fibrinogen was not in the very low. So this is where I started like having some doubts in my mind. We should do something different. Otherwise, this guy is going to die. And at that point, we only had 2 parameters to pull a tentative diagnosis of this. We did not have all of these parameters. We had the poor response to FFP, and we had the factor 8, which was disproportionately low compared to the other factors. I've seen the IC, I've seen other conditions where there is consumption of factors. They are well balanced, and I've never seen factors being less than 1%. So this disproportionate problem just made me feel that there is a factor inhibitor of 8. We didn't have a mixing study at that point, and we didn't have an inhibitor test. So we worked with a possible diagnosis of factor 8 inhibitor, and you can imagine the fight that I had to go through to get Novo-7 or recombinant factor 7A, which is a very expensive medication without a clear diagnosis, to kind of save this guy's life at night. So we gave him a dose of Novo-7, and in few hours, 3 hours, the pressures went down from 50 micrograms per minute to 10 micrograms per minute, and the hemoglobin stabilized. And the next day, we got our mixing study, which I gave you, and we got the inhibitor level, and it's a 5 Bethesda, a factor 8 inhibitor. We dosed the inhibitors in Bethesda units. 5 is kind of the cutoff between a marked inhibitor, a high intensity inhibitor, and a low intensity inhibitor. The main difference is if you're less than 5, you can try to kind of bypass the inhibitor with high doses of regular human factor 8, factor 8 replacement. But when the inhibitor is high, you either have to bypass it with an activated factor 7A that kind of unleashes the coagulation cascade by bypassing it totally, or by using porcine factor 8, which we ended up doing, to create a maintenance artificial environment where there is factor 8 and allow the healing. And the third thing is you can use activated prothrombin complex, which was called FIBA, and which kind of has factor 7 that's active, and it overloads the system, and it stops the coagulation. The very curious thing is that we don't have a clear etiology for why the factor started. When I was thinking DIC, dilutional coagulopathy, maybe inhibitor, but this did not make sense. I started thinking this does not make sense. This guy came with normal coags. Why did he develop abnormal coags the next day? And what I called unleashed coagulopathy doom. So I reviewed literature. There are reports where you have post-surgical development of a factor 8 inhibitor. It's not really well known why. People think that maybe use of thrombin patches during surgery might activate some immune response, or there are some antigens that are produced that are released that lead to this immune response. I wonder, and in general, it's 3 to 4 days, sometimes a few weeks after the surgery. I wonder if this guy had some priming of his immune system when he initially had the perforated ulcer in the past, and this was kind of a boost again with exposure to some antigens. This is my theory. And then the next day, he immediately unleashed the inhibitor. It's very interesting. We started on steroids. You can also use plasma exchange or IVIG or rituximab to suppress the inhibitor, which is also another part of the treatment. The patient is fine. His hemoglobin has been stable around 13, 14. Still critically ill, but we're actively replacing the factors to try to artificially have him at a decent level.
Wow, what a case. What fantastic teaching, Fernand. And it just makes you wonder that what maybe wasn't the globus tumor itself in 2020, but yeah, maybe there was something priming about that surgery that made this postoperative antibody production so rapid onset. Do you want to get any more comments or just turn it over for teaching summary? That was just beautiful, Fernand. Thanks for sharing just the whole process and the true real life situation of, right, you didn't have a final diagnosis, right? You were headed towards it, but in the middle of the night had to advocate for starting a treatment. And what a lucky patient to have you there to actually advocate for getting this product, recombinant product, being released for the blood bank and available even without a final diagnosis. That's how it works in the real world. With some uncertainty, we need to start treating, and you help save this man's life.
I think you really did, Fernand, and because it's not just that, the presser requirement came down, and if this had been delayed, he would have just been on more pressers for longer or whatever. If this is hemorrhagic shock, right, and you're exsanguinating, the treatment of that is just to keep the tank full as fast as you're bleeding, to keep up with the transfusions, and that's just really hard to do. So the fact that the patient was on high dose pressors, like, that's not how you treat hemorrhagic shock, right? That just means that there was like desperation, and it was so hard to keep up with the amount of bleeding that that was the last resort to try to keep the map up. So this treatment very likely saved his life, and if not, saved his digits from suffering from the higher dose pressors and stuff. So yeah, kudos, and thank you for sharing this great case. Sukriti, do you want to sum up some of the teaching points just for one more cycle for us?
Sure. Thank you, Fernand, and thank you to the discussants and Steph and Zavin. So when we started thinking about this case, we began investigating the symptoms, which was initially difficulty breathing and acute on chronic abdominal pain. And what I really liked was how Zavin specified how we think about this and how we think about pathology across two contiguous anatomical sites. So this falls into two buckets, essentially: the anatomical aspect, which is a mass effect can cause pathology in both these sites, or a physiological, like something like of inflammation that can track across the diaphragm, and that again opens up the possibility of infections, malignancies, autoimmune conditions, drugs, and endocrinopathies. The second aspect of the case that we discussed was the severe postoperative bleeding, thinking about this in three buckets: whether the integrity of the vessel was affected, whether the platelet plug, there was a problem in the platelet plug, either due to dysfunction of the platelets or because there was a decrease in the quantity of the platelets. And the third bucket, was there a problem in the coagulation cascade? And what we did in this case is that we didn't spend a lot of cognitive energy thinking about the chief complaint, essentially, but by iterating our problem representation frequently, we were able to reframe this case and also find our pivot point in this case, which was essentially that this patient had come with recurrent duodenal perforation and severe post-operative bleeding. And that essentially guided how we progressed through this case. So as we began collecting clues with our physical and our past medical history, we thought about this abnormal hemostasis in two ways. Was this a problem of dilutional coagulopathy and DIC, given that this patient had had massive transfusion and a disproportional replacement of the RBCs versus the platelets? Or were we dealing with an isolated factor deficiency? Initially, we approached this as the isolated factor deficiency being less likely, given that he was an older gentleman. And we think of these as usually being genetic, but they could also be autoimmune. And then if we have to consider our autoimmune an autoimmune acquired process, we think about three buckets. Is this a paraneoplastic process? Are we dealing with an atypical viral infection? Or is this part of a larger autoimmune process? We also discussed some of the specifics of a mixing study, and essentially what a mixing study does is to help differentiate between a factor deficiency versus a factor inhibitor. So the second step is to look for an antibody after the mixing study. And we also learned from Zavin, this was helpful to me as a medical student, that while interpreting the vitals in a person with shock, you judge the severity of the shock based on the dose of the vasopressors, not on the vitals themselves. And finally, we basically framed this case as being a functional factor 8 deficiency. And then, as Fernand taught us, given that this patient also had a poor response to FFPs, this to him suggested that there was a factor 8 inhibitor that was most likely. And then finally, I think what was the learning point was we also added to our illness script of factor 8 inhibitors, a post-surgical factor 8 inhibitor.
So well said, Sukriti. Thank you for summarizing the teaching, and thank you, Kirtan and Mario, for discussing this with us. Really enjoyed hearing your thinking and your teaching out loud. Look forward to seeing everyone next Wednesday. Take care.
Bye, everyone.
Bye.